Very good afternoon and evening to everyone. My name is Dr. Chee Kwang. Firstly, I'd like to thank the organizing committee for inviting me to give a talk today on the DAR Alliance conference on mixed insulin and fasting. So, as just a disclosure, firstly, I've none to declare in terms of financial disclosure. An overview of my talk will start with an introduction. I'll just put a bit of case study to put things in perspective. Because of limitation of time, studies on premixed insulin during fasting, we just be touching on two studies, then management for premixed insulin, and last but not least, a few take-home messages for the audience itself. So let's just start a bit of introduction. Fasting, as we understand, represents one of the five main pillars of Islam. It involves abstinence from food and fluid from sunrise to sunset. We are all very familiar with the EPDS study, which has shown that about half of patients do fast for more than 15 days. And the MODA global survey showed that 15.5% of the participants were on actually pre-mixed insulin, with a higher proportion among those aged less than 65 years of age. However, the concern with fasting is the potential heightened risk for complications, and this holds a true concern in patients who are particularly on insulin therapy and how we're going to manage them. So this comes to my case study, just to of a patient that is actually a real patient of mine. He's Mr. AJ, he's a 56-year-old male. He's got diabetes mellitus type 2 for the last 14 years with microalbuminuria, hypertension, and dyslipidemia. He's currently on human insulin biphasic, mixed start 30 units pre-breakfast and 20 units pre-dinner. Metformin extended release, 2,000 milligrams once daily. Perindopril, 8 milligrams once daily. Amlodipine, 5 milligrams once daily. And atorvastatin, 20 milligrams once daily. History review revealed that he does have one episode of mild hypoglycemia, which he can manage and resolve by himself. It happens about once a month. He does SMBG only occasionally, and this tends to be when he's not feeling well, whether he's having hypo symptoms or he just feels a bit dizzy or symptomatic. He had no recent admissions for diabetic ketoacidosis, and on questioning, he managed to fast for a full 30 days last year. His latest investigation showed an HbA1c of 7.6%, or if you look at IFCC, it would be 60 millimoles per mole. His urinary ambient ratio is 4.5 milligrams per millimoles, and his estimated GFR based on CKD-EP is 93. So he came to clinic because he wanted to inquire about fasting during Ramadan. So of course, firstly, we want to know what his current risk for fasting, whether it's high risk, moderate risk, or low risk. And if you look at this slide, which shows all the different scoring parameters that we do, he scored one for duration of more than 10 years, one for hypoglycemia less than 1 time per week, multi-daily mixed insulin, which gives him 3 points, and his HbA1c levels was 7.6, which gives him a 1 point. There's no macrovascular disease. His eGFR is above 60. There's no scoring. He should monitor his sugars, but it's not conducted optimally. Therefore, he gets a 1 point for that. The rest of it in the physical labor is 0. Fasting hours is less than 16 hours in my country. And he's not frail, and he's got no cognitive function issues. And he had a bit of a overall negative experience that he was feeling a bit shaky when on further questioning towards the end of the fasting itself. So when he looked at his scoring, risk score is actually 7. And therefore, his current fasting risk level is actually considered high. So but you told the patient not to fast. However, like most patients, they do decide to fast, and because of the 5 pillars of Islam and their determination to do so. So it's quite important to ensure they have a structured Ramadan-focused education, looking at meal planning, dietary advice with dietitian, making sure appropriate timing and exercise, blood glucose monitoring, which is very quintessential when it comes to fasting, and knowing when to end the fast, which is when they have hypoglycemia, defined as blood glucose less than 3.9 millimoles at any time during the fast. Blood glucose levels are about 3.9 at the start of the fast, and the patient is taking insulin or sulfonylureas. There's hyperglycemia blood glucose of more than 60.7 millimoles per liter. And last but not least, they need to know to recognize and manage acute complications and when to seek medical help in such situations. So the medical management when it comes to pre-mixed insulin comes with a very challenging angle from the point that the majority of patients that we have are actually on pre-mixed insulin, and this tends to be on a low ratio pre-mix. And this provides inadequate prandial cover in the evening for the resultant postprandial hyperglycemia. And doses of prandial insulin cannot be adjusted independently, which can lead to risk of both postprandial hyperglycemia and hypoglycemia after suhoor. So the options, of course, would involve using a higher ratio premixed insulin iftar, changing to an alternate regimen. And I missed the third point, which is, of course, to adjust the dose of the insulin dose that the patient is on. So this brings me to my subsequent slide of looking at a study it's not a new study in that point. So study which I'm sure we all are very familiar with by Hui, published in the journals in 2010, International Journal of Clinical Practice, looking at comparison of Humalog mix 30 with human insulin mix 30 in type 2 diabetes during Ramadan. So the aim was to compare hypoglycemic events, glycated hemoglobin, H1C, and changes in body weight among Muslim patients with type 2 diabetes receiving Humalog mix 50 and Humulin mix 30 twice daily during Ramadan fasting. So we divided into two groups. The group one will involve switching the patient from a mixed 30 to iftar insulin to Humalog mix 50. However, they will maintain the mixed 30 for suhoor meal. The second group will continue the usual dose of mixed 30 for both suhoor and iftar with no dose adjustment. So the results show that, overall, they managed to enroll about 52 patients. The group 1 showed a reduction of about 0.48% HbA1c, while the group 2, which was the one that did not change the type of insulin they were on, had an increase of 0.28%. Most importantly, there was no statistical difference in terms of hypoglycemia between group 1 and 2. So the authors concluded that changing to Humalog mix 50, which has a higher postprandial lowering effect, may lead to improvement in glycemic control with no increase in hypoglycemia. So this study shows that, okay, changing the patient to a mix 50-50 may be a good choice, and it doesn't cause harm despite increasing the short-acting component of the insulin, but in terms of hypoglycemia. This brings me to a more recent paper. There was also published a similar paper, the International Journal of Clinical Practice. It was by Issam Hajaji from Libya, and it's actually looking at the comparison of analog insulin mix 50-50 with human insulin mix 30-70 in patients with type 2 diabetes during Ramadan. Once again, the aim is to test if changing the iftar insulin to a 50-50 analog insulin from a 30-70 human insulin at the same total dose leads to improvement in the postprandial blood glucose level, which is taken as after the main meal. There was two groups. The first group was switched to a 50-50 mixed insulin analog after iftar meal, and the 75-25 mixed insulin analog for suhoor meal. The second group continued the usual human insulin mixture of 30-70, and if they were on oral agents, this will actually continue as usual as well. Measurements done was looking at fasting and 3-hour postprandial and pre-suhoor blood glucose. And they look at HbA1c pre and post-Ramadan, hypoglycemia, events. They look at the patient's weight in terms of pre and post-Ramadan as well. So there was 40 patients in this study itself. What they found was that group 1, which is the one that has switched to a 50-50 mixed insulin analog at iftar and a 75-25 mixed insulin analog for suhoor, had a lower postprandial glucose reading after their main meals, and they also had a lower HbA1c. They did not find significant differences in body weight and hypoglycemia, although there were small numbers of reported hypoglycemia in both arms of the study itself. But this was not significantly in terms of an statistical analysis. So the conclusion from this study is that, switching a patient to a different type of insulin which tackles the postprandial glucose can be achieved by giving this patient a 50-50 mix of mixed analog insulin. Hence, from these two studies, I hope it kind of shows that you can fast safely, provided you do little adjustment in terms of the type of insulin combination that you do. The studies looking into all these very limited, of course. And there was actually one study that was actually brought to look at the profiles when they look at reducing doses are done by 25% of the insulin. And that's where all the recommendations that have been published in the IDF and the DAR, in collaboration with the DAR Alliance, in terms of management of patients with premixed insulin was developed. Those on once daily dosing of premixed insulin, they will take the normal dose at iftar instead. While those on twice daily insulin dosing, premixed insulin, they will take the normal dose at iftar, and they should reduce their suhoor dose by about 20 to 50%. While those on 3 times daily dosing, they will just merely omit their afternoon dose, the lunch midday dose. They will adjust the iftar and suhoor dose, and this will be done by a titration that's shown below, where you adjust the insulin doses up and down depending on the blood sugar level. So if a patient's blood sugar is 4.2 millimoles per liter, you reduce the patient by 2 units. And this idea of trial fast is very important. It's something that I encourage my patients to do, and is to advise them to fast for 3 consecutive days before Ramadan itself. Because this can help the patient to actually detect hypoglycemic risk, and it also helps to guide them in terms of self-titration of their premixed insulin dose. So no, it's not one size fits all. We have to titrate it and individualize in terms of the dosing itself. It may also help to identify fasting or postprandial hyperglycemia, so the doses can be adjusted accordingly. However, we must understand that this needs to be taken with care, because careful exploration of the information is required due to, there are different lengths in terms of fasting depending on where you are on the globe itself. Some countries fast more than 16 hours during Ramadan. And the most ideal time is, I always say, is about 2 weeks before the fasting month itself. So somewhere along the midways before Ramadan, around Shaban. So this brings back to my last slide in terms of the take-home messages. I cannot emphasize enough how important it is to re-stratify the patient when it comes to fasting in Ramadan with patient on premixed insulin. And of course, the importance of structured education on how to eat a balanced meal to ensure they can fast safely through the day without hyper or hypoglycemia, and having a dietitian's involvement. And appropriate modification and individualization of insulin regimens, because this is the key things when it comes to insulin treatment. There are patients that may not need any dose adjustment, but there are patients who may need dose adjustment. And this is very much where the trial fasting becomes a very important tool for you to guide the patient to fast safely. And with that, I would like to thank your attention and the audience for my talk today. Thank you very much.